So hi, we are student-led discussion group number 4. I'm Jennifer Gilchriest.
I'm Kelly Gilmartin.
And I'm Anna Monley.
So our articles was Disparities in Quality and Access to Care for Children with Developmental Disabilities and Multiple Health Conditions. Next slide. So in this study, the authors analyzed access and quality indicators among categories of children with special health care needs. Indicators were based on survey data from the 2009-2010 National Survey of Children with Special Health Care Needs. The responses were categorized into 7 condition groups based on health type. The goal of the study was to shine a light on the condition of systems of care for children with special health care needs by examining survey results related to the 6 Maternal Child Health Bureau indicators. A review of the study's sources revealed similar studies and articles that further confirm the findings of the study. Next slide. In 2000, the Maternal Child Health Bureau of the HRSA, along with state Title V programs, instituted 6 quality indicators that reflect well-functioning systems of care for children and youth with special health care needs. The National Survey of Children with Special Health Care Needs, or NSCS-HCN, also began in 2000 and acts as a feedback channel to assess the indicators. The indicators listed in this box are taken from the article. Partner in healthcare decision-making, medical home for children, healthcare transition services into adulthood, community-based services and access, adequate health insurance, and early and continuous screening. Next slide. The study utilized previous work to highlight the continued disparities in healthcare for different conditions as they relate to the 6 Maternal Child Healthcare Bureau indicators. The authors note that there are 2 separate concepts within the indicators, access and quality. So in the first study, Halfon et al., they examined the life course health development, past, present, and future. This study summarized the progress of the integration of the life course theory into the maternal and child health population and its potential to potentially transform outcomes. The second study that was heavily relied on, Nageswaran and Associates, was an association of functional limitation with healthcare needs and experiences of children with special healthcare needs, published in the Journal of Pediatrics. This study analyzed the 2001 National Survey data and found that variation in access and quality indicators were strongly associated with the child's level of functioning and other factors that contributed to health insurance that were contributing, such as health insurance and socioeconomic status. The article further presumes that deficient access to care is a culmination of poor coordination, lack of providers, and insufficient insurance coverage. 3 other studies examined access to care indicators and produced similar conclusions. Those were listed in the sources under Cheery, Krause, and McGrath. Those studies examined children with different diagnosis and their access and quality of care related to children with autism. The second study was for children with mental retardation, autism, and other special healthcare needs. And then the final one was access to genetic counseling for children with Down syndrome, autism, and intellectual disabilities. The third study that was heavily relied on for this article was DuPaul and his article, Medical Home Care for Children with Special Needs, Access to Services and Family Burden. This study used data from the 2005-2006 National Survey, subjective to 5 different diagnoses groups. The study found children with multiple or complex conditions were less likely to have a medical home and were more likely to have higher family burden of care. Again, findings suggested socioeconomic status affected access. Strickland, excuse me, in 2014 published Assessing Systems Quality in Changing Healthcare Environment. This assessed quality from the 2009-2010 national survey based on the maternal child health 6 quality indicators to determine the extent to which children had access to a well-functioning system of care. The study found that only 24.4% of children and youth with special healthcare needs had an unmet indicator. Next slide, please. Nagus Warren in 2011 published, "Do children with developmental disabilities and mental health conditions have greater difficulty using health services than children with physical disorders?" This study aimed to determine whether the MCH core outcome for ease of use of health services differs between children with developmental disorders, mental health conditions, and physical disorders. The study found that children with DD had 2.3 times greater odds of having difficulty accessing care compared to children with physical health conditions alone. Children with mental health conditions had a 2.6 times higher odds. So Chen and his quality measures for primary care of complex pediatric patients was a literature review that this article utilized for complex pediatric patient core measures and associated indicators for development of quality measures. This lit review found 35 measures were found to be valid for assessing the quality of primary care for complex patients and grouped them into certain domains. The last heavily relied on study was Vora and Associates in 2014. They looked at access to services, quality of care, and family impact for children with autism, DD, and other mental health conditions. This was a cross-sectional study that they drew from the 2009-2010 National Survey of Children with Special Healthcare Needs to assess perceived access to quality services and family impact, and concluded again that indeed caregivers for children with special healthcare needs, especially those with autism, face significant barriers in access to services and face adverse family impact. So defining the problem. Are we on the right slide? So the problem is clearly defined in the article as the authors aim to add to the literature by delineating disparities in maternal child health access and quality indicators for children with different types of conditions and combinations of those conditions. 20% of children and youth in America report having a special healthcare need. Often families shoulder the burden of care and can experience undue stressors and marginalization. Children with more complex health and behavior are at a higher risk of experiencing disparities in the healthcare system and are at risk of experiencing medical, social, and developmental setbacks. Children with special healthcare needs are a relatively small but mighty population as they require a higher level of support for quality of life. The public health significance rests in the children's outcomes and the caregiver burden. Improved systems of care lead to equitable access, which produces better health outcomes and fiscally responsible spending on services. The authors align the study goals with the HRSA Maternal Child Health 6 quality indicators, as well as the Healthy People 2020 goals, which are reported at the state level Title V programs. The study's authors note that this is the first study of its kind to analyze all 6 Maternal Child Health Bureau indicators in children with different condition types, making it an innovative study that draws from previous literature and research and adds to the current focus area. So for the literature review, next slide, Anna, thanks. The literature review was sufficient and includes a broad range of contributing knowledge. The work cited included a range of studies that examined access or quality through several years of the national survey data and against various conditions. References built upon existing evidence and were current up to the writing of this article, which was in 2016. Excuse me. Works build on a study from 1990 that supports the designs of surveys using cognitive science to improve reporting accuracy. Another 2003 study provided a basis for work that examined survey results for access indicators among children with special healthcare needs. The life course development perspective was considered and included in the work cited. References included current studies, but also include foundational articles relating to the Maternal Health Child Bureau framework, as well as national goals. Next slide, please. The theoretical framework utilized in this article was based on the life course theory as cited in Halfon et al. 2014. The theoretical framework fits the problem by applying the life course theory to the dynamic nature of human development and the potential to improve quality of life by health interventions at various stages. Results and conclusions also reflect this aspect of the life course theory by changing systems of care to improve quality of care for children and youth with special healthcare needs.
The main research question for this study was to identify disparities in meeting quality and accessibility indicators for children 0 to 17 years of age with different condition types based off of their disabilities, whether it be physical or mental. When reading through this study, I felt that the research question could have stood out a little more. It is stated in the title of the study and further down in the abstract, it mentions that the subjects are going to be children with disabilities rather than healthy candidates. On top of this, the candidates are being sorted into 7 groups, which are physical health, mental health, developmental disability, physical and developmental, mental and developmental, and physical, mental, and developmental. The question could have been better worded to be more specific. However, this research question can be testable after contacting families for further information. Next slide. This study design is a cross-sectional study. The National Library of Medicine shares that a cross-sectional study is a study that are used for populational-based surveys and to assess the prevalence of diseases or conditions in clinic-based samples. For our specific study, this is appropriate to answer the research questions because it is examining the population, in this case, which is children with disabilities, and how it relates to their specific conditions. In terms of the conditions, the researchers did attempt to control threats to internal and external validity. The research was conducted without bias, and for the external validity, if the study were to be replicable in the United States, it could be high, but in other countries, the results could be skewed due to different nationalities, due to different demographics, conditions, presentability, gender, etc. For a national cross-sectional study, the sample size is adequate for its 40,242 participants in total with disabilities that will fit into these 7 categories. The sample is short of the population because I think that there would be more families that have caretakers for disabilities, especially when focusing in more worldwide access and not just limited to the United States. And there could have been families that were just afraid to step forward for this survey. The inclusion and exclusion criteria are appropriate as well, since this study participants were grouped based off of their specific conditions and disabilities and how they fit into this group. Next slide, please. The instruments and data collection were described sufficiently by addressing that they are collecting data via phone calls, through sponsored messages, and specific screening questions that will be asked to each participant who chooses to enroll in this study. When discussing the topic of reliability and validity for this study, there could have been a more reliable way to collect data rather than by the cold call, landline, or the telephone option. In any research study, there is always a chance that is conducted with bias. And for this study, it's the 2009-2010 NSCSHCN data is being used. So the results could have been skewed in favor for this study. Next slide.
Okay, so when looking at the design flaws in this study, like was mentioned, this was a cross-sectional study that was done using a national phone screening database. So one thing that I noticed when looking into some of the design flaws was that there was no data listed on the success rate as to how many individuals were contacted and how many were not able to be contacted. So we're not really sure exactly what that success rate was. And that does lead to some questions as to a little bit of data bias. Some skewing could have happened towards families, households that were able to answer calls during business hours. So for example, a household that has 2 working parents may have been less likely to be able to answer the phone to complete this phone screen, and therefore less likely to be included in this survey. And an additional design flaw, which is somewhat inherent to The population being studied is caregiver reports. They can be subjective. They can be swayed one way or the other. They're not always the most black and white way of collecting data and information. So that could lead to some design flaws seen. When looking at the outcome measures, the study authors were looking at the frequency and prevalence of the disability characteristics listed against demographic information, activity limitations, and family characteristics. Chi-square tests were performed on these condition groups against MCHB or Maternal Child Health Bureau indicators, all of which were found to be statistically significant. When looking at the collection of data quality, an adjusted odds ratio was done for each one of the aggression analyses for this study, adjusting for individual, family, and activity limitation variables. So this added a nice source of data quality assurance into the results presented. Health insurance type and activity limitations were found as significant predictors within each aggression. And this type of odds ratio analysis was appropriate within the context of the study, especially when considering that this study was meant to be in addition to the body of previous work that's been done on the topic. And then in terms of whether or not the researcher discussed these findings in regards to the theoretical framework, we did not find that this was present as a discussion or mentioning within the paper, so we did not feel like it was necessarily mentioned or discussed. So conclusions, the authors, decided to split up the indicators looked at into two categories, either quality or access. So quality included being a partner in decision-making, having a medical home, or receipt of healthcare transition services. And access was broken down into access to community-based services, health insurance adequacy, and early and continuous screenings. When looking at the trends that were identified, there was a very consistent trend across each one of these groups. So when looking at being a partner in decision-making, compared against those with just physical health conditions, all other groups were less likely to report this indicator. And it was the most significant when looking at those with both a mental health condition and a developmental disability. When looking at access to a medical home, again, all groups were less likely to report this indicator and was most significant for those with all three of the conditions listed. Receipt of healthcare transition services, again, all groups were less likely to report, and the findings were most significant for those with just developmental disabilities. Early access to community-based services, all groups were less likely to report, and again, this was most significant for those with all three conditions listed. The same was true for adequate health insurance. And when looking at whether these individuals were screened early and continuously, all groups were actually more likely to report this. So this was the one flip-flop that the authors found in the results. The exception, however, was those with developmental disability or those with just a physical health condition. So taking all of that into a broader conclusion, it was found that when looking at quality indicators, having a developmental disability, either alone or in combination, made an individual significantly less likely to meet all or any of the quality indicators. And when looking at access indicators, again, developmental disabilities alone or in combination, found to be significantly less likely to meet all or any of the access indicators, except with that exception of early and continuous screenings. So the main conclusions that were found here were that children with developmental disabilities, whether alone or in combination with an additional condition, are facing significant disparities in the quality and the access to their healthcare services. And additional state and federally funded programs should really be looking at this disparity, trying to identify the gaps and adding on additional training and additional education for healthcare personnel that are working with this specific population. When considering whether or not this study could be continued, expanded, it absolutely could. It could be expanded to include some additional criteria under the umbrella of care and access, trying to delve a little further under the surface to understand the root cause of some of these gaps in coverage that are really affecting children with developmental disabilities and their families and caretakers. When considering ethical considerations, there's not a whole lot mentioned by the authors. However, it was mentioned that IRB approval was received, as well as compliance with ethical standards. There's no additional expansion on what that meant, but this was at least approved by the local university's IRB. And then looking as to whether or not descriptions of consent procedures, safety nets, there really was not much listed here. The only thing that was mentioned was that this information was gathered through a national telephone screening initiative done by the CDC's National Center for Health Statistics. But there was no description as to what the actual consenting procedures were or any safety nets that may have been included. There were no other ethical concerns, however, that were brought up by this paper. So delving into class questions. The first class question that we received was, what do you think accounts for the differences in quality and access to care for children and young people with developmental disabilities as compared to those with physical health conditions? And how could this disparity be addressed? So the complexity of care when looking at kids with developmental disabilities can be really significant when you compare it to those with just physical health conditions, especially when it's taken in combination with an additional condition type, as was seen in this study. So developmental disabilities along with the physical health or along with the mental health. That can really require a complex care team that has to be pulled in from different subspecialties, and that requires a lot of communication between those care teams and between those patients. So it's a really it's a ripe opportunity for gaps in coverage and communication to occur for these patients. And the patients and families, as a result, just may not be given the tools and resources that they really need to most effectively utilize all the healthcare services that are provided to them. So this could be addressed in a variety of different ways. This medical home concept to bridge gaps in care coordination. The state Medicaid regional accountability entities is a task force that's tasked with tracking early and periodic screening, diagnostic, and treatment data, as well as outreach to patients and families to connect them to services. And then in addition, just really delving down again, the expansion of this study to go deeper into the socioeconomic and demographic data to understand not only why this is happening, but figure out maybe where we could better place outreach clinics and public health and better implement public health education campaigns. These are all really good options for a way to address this disparity. And I'll leave it open if you guys have anything to add before I move on.
Yeah, we can go to the next slide. Good job, Anna. Thank you. So I'll take this next class question from Amanda. Since access was somewhat higher than quality in several indicators, what might explain the lack of access to a medical home? What we thought that maybe lack of providers could account for lack of a medical home in some areas. Primarily, the mark for the yearly well child visits is under par, especially in the state of Colorado, when it comes to children and youth with special health care needs. So they're not making it to the doctor's office for their yearly well child checks. Data from the 2015-2018 National Health Statistics reports that 20% of children 3 to 17 years old that live in rural areas, only 83.4 of those children received a well child check, which is usually performed at a primary care office. So the lack of a medical home could be based on lack of providers, or it could be that the survey wasn't clear on exactly what a medical home is. And so some of those respondents were unsure on how to answer that. And Kelly, did you want to take the last question?
Yeah, of course. So this last question is from Olivia, and it says, why do you think children with a physical health condition were the least likely to have access to early and continuous screening compared to other conditions children had? So this could be due to the acute and later onset of a physical health condition versus a DD that is present early in infancy. At times, parents on the sorry, a lot of acronyms, CSHCN survey don't recognize that early screening did occur, in that yearly well child check is part of continuous screening. And this can be really hard, especially like in the previous question in rural areas where parents just don't have all of the tools and education needed to go for yearly checkups or to know what is needed, especially for kiddos who have disability. And this question could be misrepresented as some have difficulty understanding what exactly the EPSDT does.
All right, so that's it for our SLD Group 4 discussion. Thanks, guys.